Welcome everyone to our Vaccines, the Future of Cancer Treatment. We'll get started in just a minute. We're just going to give everyone a chance to sign on. Thanks. Welcome everyone. The program will begin in just a moment. Well, welcome to our Vaccines, the Future of Cancer Treatment with Dr. Sasha Stanton. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at SHARE. But before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 42 years by offering the support of those who've been there. SHARE offers many services, including a helpline, telephone and in-person support groups, and educational programs, and many of these are specifically for those living with metastatic breast cancer. All services are free of charge to participants. For more information, you can visit our website at sharecancersupport.org. All participants will be muted during the presentation. When Dr. Stanton finishes speaking, we'll open up for questions and answers. You're welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, please remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. So now I'd like to introduce our speaker. Dr. Sasha Stanton has an MD and a PhD from the Albert Einstein College of Medicine in New York. She completed her residency in internal medicine at New York Hospital Weill Cornell Medical Center and her hematology oncology fellowship at the University of Washington Fred Hutchinson Cancer Research Center. Dr. Stanton is an assistant professor in the Department of Medicine, Division of Oncology at the University of Washington, and an assistant member in the Clinical Research Division of the Fred Hutchinson Cancer Research Center. Her research focuses on antigen discovery and vaccine design for vaccines for breast cancer prevention at the University of Washington Cancer Vaccine Institute. Clinical work with the Breast Oncology Group at the Seattle Cancer Care Alliance. Welcome, Dr. Stanton. It's all yours.
Thank you so much, and good morning or afternoon, depending on where everybody is. So I'm Sasha Stanton. I'm coming from the University of Washington, and today I'm going to discuss our vaccines, the future of cancer treatment, particularly in focusing on breast and ovarian cancer vaccines. And this is kind of a wide swath discussion talk, so I'm also happy to answer specific questions after the discussion and over email if anyone has any further questions after that. So I first want to start with the fact that there actually are already vaccines, and particularly prevention vaccines, that are FDA approved for cancer. And the two that are most commonly known are the HPV vaccine, which is used for cervical cancer prevention, and the hepatitis B vaccine, which is used for prevention of both hepatitis B infection and hepatocellular carcinoma. And what these two vaccines have in common are that they are both virally mediated cancers. So they're cancers that are induced by viruses, and we're able to vaccinate against those viruses to prevent the cancers. They have been very exciting work done on these. For example, particularly outside of the United States, in Taiwan, hepatocellular carcinoma, and particularly in young children, so between the ages of 5 and 29, were causing about 400, there were about 454 cases of this over about a 10-year period in the late 70s, early 80s. And when they started vaccinating when children were first born with the hepatitis B vaccine, hepatitis B is endemic in Taiwan and carried by many mothers, then this reduced to 3 cases. So vaccines, and particularly vaccines in cancer prevention, are very possible. But now what we need to do is move this forward into vaccines for cancers that are not virally mediated, and really be able to develop vaccines that can work for a wide variety of cancers, including breast and ovarian. So very complicated slide, but I really wanted to show you that there are many different components of a vaccine that we need to determine when talking about vaccines. So as we all know, vaccination is giving you something that teaches your immune system about a thing that it should destroy. So basically what your immune system is trying to do is your immune system is a balance between recognizing what yourself and not developing an autoimmune or destructive response against your own body, but recognizing things that are abnormal and that are dangerous to your body, such as viruses and bacteria. And what vaccines do is they teach your immune system in a way that isn't toxic to you how to recognize these things that are dangerous to your body, so that when your immune system sees them in your body, it can destroy them. If you think about the flu vaccine, every year the CDC decides which parts of the flu are most likely to cause problems, and they develop a vaccine so that you can see those parts of the flu and your immune system recognizes them, so that when it sees them, when you're exposed to the flu, it can destroy them, hopefully. As I have just gotten over the flu, I can tell you that the vaccine this year was not quite where we would want it to be. But so basically, when we're talking about a cancer vaccine, we are looking for a source of proteins that are particularly associated with the cancer that we can teach your immune system to recognize and destroy the cancer. And there are many, many different types of vaccines that are out there and that we have been looking at to do this. I'm going to be focusing a lot on DNA vaccines because that happens to be what my lab is focusing on, but there are also host cell vaccines where you're vaccinated with a cancer cell that's killed in order to really teach your immune system to see all parts of that cancer cell. There are dendritic vaccines. There are peptide or protein-based vaccines. So one source of figuring out of vaccination is the type of vaccine. The second thing is the type of adjuvant. This is the chemical that's included with the vaccine to basically get your immune system interested in what you're vaccinating against and bringing your immune system to that area so that it can activate. Our adjuvant that we use in the Cancer Vaccine Institute is GM-CSF, which any cancer patients who've received chemotherapy and gotten Neulasta are very, very familiar with. We basically use it in that we give our vaccine in a mixture with it so that when it goes into the skin, it recruits all of these dendritic cells and immune-presenting cells to the area. They take up the vaccine, go to the nearest draining lymph node, and that's where they interact with specific parts of the immune system to activate an immune response. And these can be, again, a wide variety of the immune system. We typically vaccinate with T cells. This is a cytotoxic T cell or a CD8 T cell. There can also be CD4 T cell vaccines and B cells. Now, the hope is that with the vaccine, we teach the T cell to be active and recognize those particular parts of the protein of that cancer. And then that cell goes throughout your body. And when it sees normal tissue, it says, okay, that's normal. That's not what I want to attack. But when it sees a cancer cell, it activates and is able to kill the cancer cell. as well as induce something we call immune memory, which is, for example, when you've received a vaccine for example, measles and mumps, you are able to trigger memory so that if 10 years later you see measles or mumps infection, you're able to fight that with immune memory T cells that are re-stimulated and able to fight the infection. And so really these are the components of vaccines that we are looking for across the research, across where we're studying for these. And so basically what we're trying to do in cancer is we're trying to trigger, to treat your cancer much like we treated those viruses. We want your body to see your cancer as not self, as something that it can destroy. And really, there's a lot of words on this page, but what we're looking at here is a balance. It's a balance between the type of immune environment or type of immune response that your body triggers to a bacteria or a virus, which is a type 1 immune response, which inhibits blood vessel growth. It activates those cytotoxic T cells that can directly destroy the tumor or the infection, and it triggers this memory, this immune surveillance that allows the tumor to continue to be attacked by the immune system. And we have found across many different cancers that developing this type 1 immune response triggers tumor regression and is important for anti-tumor immune response. However, your body sees your cancer, while abnormal, as part of you. And so naturally, it is going to try to trigger more of an immunosuppressive and less inflammatory response. The tumors are also pretty good at tricking your immune system into thinking that they need to dampen down the immune response and not trigger an immune response. So when your body is seeing a cancer, the immune system is seeing it more like a wound and less like a viral infection that it wants to destroy. So this type 2 immune response can be pro-angiogenic. It can trigger growth of blood vessels, because if you think about a wound, you really want a lot of perfusion to help heal that wound, tissue remodeling, and unfortunately immune suppression. So when we're thinking about vaccines and thinking about a lot of immunotherapy in cancer, what we're really trying to do is we're trying to flip this balance more toward this anti-tumor type 1 immune response and away from this pro-tumor type 2 immune response. And so what a lot of work has been done in right now is really to define what is the immune response that happens at baseline with cancers, and then be able to really figure out what immune therapies of the panoply of immune therapies that we have that can decrease cancer proliferation while increasing that type 1 immune response and allowing either treatment of the tumor or prevention of the tumor. If you've been seeing any of the current studies on CD8 T cell infiltrate, or in breast cancer, the percentage TIL that are in the tumor. TIL just stands for tumor immune lymphocytes, or tumor infiltrating lymphocytes. Basically, that is this immune score. That is trying to figure out this baseline score and then be able to use vaccines and adjuvants, cytokines, immunomodulatory antibodies, and those include things such as Herceptin, which is a monoclonal antibody against the cancer, and it has a immune role as well as an inhibiting HER2 receptor role. There are many, many ways that we can try to use our immune system to try to treat cancer, and I'm hoping that this will be a little clearer for how we're thinking about using vaccines in this way. So one of the ways to consider vaccines is much like we would use for HPV or for hepatitis B, use them in prevention. And basically what this would be doing is, before we get an invasive cancer that has a lot of immunosuppression, the cancer itself is triggering a lot of immunosuppression, try to develop an immune response against earlier types of cancer. And I'm showing this with breast in particular because we don't have the same way of detecting earlier ovarian cancers quite as routinely as we do with breast cancer. But we detect a lot of ductal carcinoma in situ and hyperplasia in women prior to them developing breast cancer. And if there would be a way to vaccinate during that stage before they've developed into invasive breast cancer, the hope would be we would prevent these women ever actually ending up developing invasive cancer. And we know that the immune system sees the tumor starting very early. And basically what you're seeing on this top panel here is H&E staining, which everyone has when they have a biopsy of their breast or of their ovaries. It's a standard stain, and you can see these dark cells forming around the cancer, and those dark cells are immune cells. CD45 is just a lymphocyte stain, so it's just showing that these dark cells correspond to immune cells. So we know the immune system sees the cancer and tracks to it. The problem is, and this is looking at breast cancer, as we develop the cancer, we also tend to develop the wrong type of immune response. So we see a lot of these Th2 regulatory T cells that actually suppress the immune system instead of increase the immune system. And they're particularly high in ductal carcinoma in situ, and they get even higher in invasive cancer. CD68 cells are macrophages, which similarly in breast cancer have been shown to really suppress the immune response. So what we want to determine is to find ways to activate anti-tumor immune response, so a pro-inflammatory immune response, and really in understanding basic immunology, we found that that is easier in these pre-invasive lesions that don't have such immunosuppression that we see in invasive cancer. And this is for many reasons. One of the reasons is simply that with invasive cancer, many women have to have had chemotherapy, which does suppress your immune system and your ability to respond to a vaccine. Secondly, the cancer itself can suppress the immune response against it and becomes more strongly able to do so as you develop and have a more advanced cancer. And the cancer also figures out ways to get around the immune system by simply blocking the immune system's ability to see it. So it develops these fibrous sheaths that basically prevent immune cells from just even penetrating the cancer or seeing the cancer. And so that's really the thought between using these precancerous lesions that haven't really established their immunosuppression and they haven't really established their structure as well, and allowing the immune system to destroy them. Furthermore, DCIS and these pre-invasive lesions have a lower disease burden. They're growing a lot slower. The patients all have very intact immune systems, and really the hope would be that vaccinating in these areas would both destroy the pre-invasive cancer, would destroy the DCIS, as well as would trigger memory that would allow immune memory, so that would allow, would any of this ever recur, or would invasive cancer, God forbid, recur, that would also be destroyed before it developed a really established tumor. And we know that the immune system is seeing these tumor-associated antigens, and I will talk about this more. These are parts of the tumor that are overexpressed, and we know they're seeing it very early because we see antibodies. So we see an immune response, a B-cell antibody immune response in the blood of women prior to even them having detectable tumor. And so this is work that was done in my lab, or in the Tumor Vaccine Institute, Cancer Vaccine Institute, that was looking at 3 proteins that we knew to be overexpressed in breast cancer, and particularly in early breast cancer. And we found when we looked in the blood of women this is blood from women from the Women's Health Initiative. So this was a very large study that was looking prospectively. So they collected blood in postmenopausal women who had not and then followed these women to see many different things. They were looking for heart disease and menopausal, going through menopause, and breast cancer was one of the many factors that they were looking for in these women. So looking at 98 women who would never develop breast cancer and 98 women who would go on to develop breast cancer, we could see these autoantibodies against tumors in the blood of those women up to 150 days prior to their diagnosis of breast cancer. So that we know that the immune system is seeing these early tumors and the immune system is responding to these early tumors. But if you'll remember back to that balance slide, the B cells and a humoral or B cell immune response tends to trigger more of a immunosuppressive type 2 response. So now could we take those same targets and try to develop a T cell and a type 1 T cell immune response to them? That would really be something to look for prevention and to try to switch how your immune system is seeing these tumors. We know that immune infiltrate does have a role in prognosis of ductal carcinoma in situ. We have looked in DCIS and found that there are increased type 2 or regulatory T cells, and that those predict patients that are going to have a recurrence of ductal carcinoma in situ. And we know on the flip side that if we find more pro-inflammatory type 1 cells expressed in the DCIS, that those patients actually do better and have less of a risk of recurrence. And in the clinic, there have been both a phase 1 and a phase 2 vaccine trial looking at trying to vaccinate patients with DCIS. So this was looking at HER2 DCIS, and this is a HER2 dendritic cell vaccine. So the type of vaccine that's used is that a patient's own dendritic cells, so these are antigen-presenting cells that activate T cells, are shown a small piece of the HER2 protein and activated, and then they're given back to the patient. And this was done prior to the patients having surgery for their DCIS. And at the time that they went for surgery, they had an increase in type 1 HER2 immune response. So that's all that HER2 interferon gamma early spot means. They had a 5-time increase in their immune response against HER2 and increased CD8 T cells in the tumor. However, with this one antigen, so vaccinating just against HER2, they did not see that a lot of the DCIS had been destroyed. In a second study that was of 26 patients, only 18% of the patients had no DCIS at the time of surgery. The remainder of the patients still had DCIS, but it had lost HER2 expression and instead was HER2 negative DCIS that had remained, really telling us that we need to look at more than just one target when we're vaccinating. We need to vaccinate against multiple targets, because we know with breast cancer and with ovarian cancer that there are many different cells in that tumor. It's not just one cell type that is triggering it. Furthermore, HER2 DCIS is about 30% of all DCIS. So we really also needed to look for a vaccine that would cover a lot more of DCIS patients. And work that I have been doing was trying to find ways to identify these early targets, because we really don't have a lot of ability to find women prior to having DCIS develop or prior to invasive cancer. And so I looked at this in a mouse population, and really all that this slide is doing is showing that targets that we identified earlier in mice were much more effective at inhibiting tumor growth in mice than targets we identified later in mice, which really led me to want to identify targets that were important for tumor growth in DCIS and invasive cancer. So remember, these proteins are overexpressed in both ductal carcinoma in situ and invasive cancer in tumors. And And I did this by going into our gene array express sets, and a lot of work has been done trying to clone or trying to figure out what proteins are overexpressed in cancer, and in a variety of cancers. This is looking at DCIS and invasive cancer, and going across multiple data sets, I found 65 targets that were overexpressed in DCIS, overexpressed in invasive cancer, and not overexpressed in normal breast, and so possible targets for a vaccine. To then determine which targets were actually relevant, which were driving the growth of the cancer, I then did a large siRNA screen, which basically means I knocked down the expression of each of those 65 genes, looking for, when you knock down the expression, which of those genes killed cancer better. And I looked at this across the breast cancer subtypes. So I had 2 ER positive, triple negative, and a HER2 positive breast cancer cell line, and I compared those to normal breast. And all that this colorful graph is showing is I picked the targets that particularly decreased survival and increased cell death in the cancer cell lines and not in the normal breast cell line. I went back for all of these targets, and these are in human breast cancer cell lines, and showed that what I'd seen using the large scale and was also would be also seen in small scale, and from those 65 targets found 16 targets that were confirmed from large scale to small scale. And I am now in the process of developing these into a multi-antigen, so targeting multiple target vaccine. What was particularly interesting about the targets that I had found doing this screen is that when we looked at women, and this is looking at the serum of women across multiple different stages of breast abnormalities. So from fibroadenoma to hyperplasia to ductal carcinoma in situ, and then to invasive breast cancer. And we found that when we looked across all of these stages, we did see increased autoantibodies to these targets. And this is just looking at 3 of the 12 targets that I am now moving forward into developing into a vaccine. And if you look at these women and look at patients that have no cancer as compared to patients that have DCIS, if you look in their blood, the autoantibodies are able to predict about 84% of women who have DCIS as compared to women who have no DCIS. And so these are, again, very good. The tumors, your patient's immune system is seeing the tumor and responding to it and developing this autoantibody response. We now want to, in using vaccines, flip this response to a T cell response and to a type 1 response that will be more likely to destroy the tumor. So that is for women who are trying to prevent breast cancer from ever developing. However, there are many women who have had breast cancer or ovarian cancer, and now we want to prevent it from coming back, or we want to prevent it from if it has come back, and even if it has come back metastatically, to get rid of any residual disease that's remaining and allow these patients to remain disease-free for as long as possible. And so this is really what we call secondary prevention, or prevention of cancer recurrence. So we know that there is something called cancer dormancy, that cancer cells are able to remain in the body and not be killed, and that the period of time between when a patient is first treated and when they recur is this time of dormancy, where these cancer cells are there and have not been completely eliminated, but have not recurred yet, or have not developed into metastatic disease. And there are many many people looking into dormancy, including cellular dormancy. Are these cancer cells arrested so that they're not growing, or is there a balance of cancer cells dying and proliferating kind of equally, and they lose dormancy when this balance gets disturbed? Are they dormant because they don't have a blood supply? They're angiogenic dormancy or immune-mediated dormancy. And what this seems to be, a very complicated slide, but just take it as the cancer cells are sitting in an area and are being held in place by the immune system. The immune system is attacking them and basically keeping them from growing. However, due to decreased immune response because of age, or decreased immune response because of getting sick and having your immune system go down, or due to a wide variety of of the tumor really adapting the immune response so that it can escape immune inhibition, these are able to recur and can become overt metastasis or a second recurrence. And really, vaccines can be used to try to mediate this balance between keeping the metastases dormant and the immune system recognizing the tumor and inhibiting it, and overt tumor growth. And we know that the immune system seeing the tumor is very important. This is one of the seminal studies in ovarian cancer looking at T cells. And so remember, the cytotoxic T cells, those are the cells that can be directly attack and kill the tumor. Patients that have increased CD8 T cells, intratumoral T cells, have improved both progression-free and overall survival in ovarian cancer, as compared to the patients whose the immune system really isn't seeing the tumor. And this is similar with breast cancer. Breast cancer patients have improved survival when they have an immune system infiltrating their tumor. That's what those lymphocyte predominant or greater than 50% TIL tumors are. They are that the immune system is really seeing those tumors, and those patients, particularly the HER2 and the triple negative patients, have a better outcome than patients that don't have the same kind of immune infiltrate in their tumor. So with these secondary prevention vaccines, we actually have other options of vaccines. So I had been talking a lot about these tumor-associated proteins that we were trying to vaccinate against in DCIS. And this is because we're trying to prevent the cancer from ever happening. In secondary prevention, we actually have the cancer that has happened. And one of the things we can consider are these cancer neoantigens. What these are mutations in the cancer that is specific to the cancer. So remember, we want to prevent an immune response that's going to happen to other normal tissue. And so these small mutations end up causing a change in the protein. And this change in the protein, excuse me, I'm going to replay that and apologize for that, can be presented to a T cell and activate an immune response, particularly against the tumor and not against normal tissue. And these neoantigens, a lot of work has been done in this in melanoma and in lung cancer, because these tend to be tumors that are highly mutated and have a lot of these neoantigens, these mutations that trigger an immune response. Breast and ovarian cancer have fewer of these. However, there are groups, particularly at the NCI and Dr. Rosenberg's group, that has been looking at these neoantigens and T cells that are specific against the tumor, and trying to develop therapies for these in breast cancer. The more what I've been talking about are these tumor-associated proteins. So these are vaccines against proteins that are overexpressed in the cancer, but that are also expressed in normal tissue. And so what we are seeing with those is that in normal tissue, your immune system sees a particular part of the protein that it always sees. This is a dominant epitope, and it develops tolerance, which means the immune system doesn't activate against that. But when the protein is overexpressed, for example, in cancer, now the immune system sees all sorts of other pieces of that protein that it doesn't normally see, and it's able to develop an immune response to that it would not normally do in normal tissue. And we see this with HER2 overexpression all the time. So when we are looking at patients who have HER2 disease, and anyone with breast cancer has probably received their pathology report and seen you have HER2 1+, 2+, 3+, and that is by immunohistochemistry, and that basically is how much HER2 is expressed. And in patients that have 3+ HER2, which are HER2 positive patients, they have a much higher T-cell response against HER2 than patients that have no HER2 expression, HER2 1+. And so this is what we are trying to target when we are vaccinating with HER2. We're trying to amplify that T-cell immune response and really allow your immune system to fight the tumor. And in the Tumor Cancer Vaccine Institute, we have had several trials looking at patients with vaccinating patients with HER2. So this is a trial of plasmid, so a DNA-based HER2 vaccine, looking at 3 different doses that went from a low dose, a 10 microgram dose, up to 500 micrograms. And basically what you can see here, these were all stage 3 or 4 metastatic breast cancer patients, and they received 3 vaccines, and they received Herceptin or trastuzumab along with the vaccines. And as you can see, when we were looking at the 3 different doses, we had the best immune response with the middle dose, the 100 microgram dose, and that immune response was actually associated with an improved survival. So that developing this immune response, and particularly this type 1 immune response. So when I say interferon gamma HER2 immune response, that's a type 1, that's a pro-inflammatory anti-tumor immune response, predicted patients doing better. We had a second vaccine that was a peptide vaccine. So now this is a small piece of protein. And this was in 22 metastatic patients. They received 6 vaccines, and they were also allowed to continue receiving Herceptin. And what we found was when we vaccinated with this small piece of our HER2 protein, we were able to see both responses to the vaccine, the piece of protein we'd given, which is what you would expect in a vaccine. However, we also saw immune responses develop to other parts of the HER2 molecule, which is what we call epitope spreading, and basically is letting us know that the immune system starts by developing an immune response to the area, what you've particularly vaccinated, and then it recognizes more of the tumor and spreads out and develops more of an immune response, and this has been associated with improved outcome. And we actually also saw what we call intermolecular epitope spreading, which is an immune response to other tumor-associated proteins, such as topoisomerase 2, which is a very commonly overexpressed protein in breast cancer, IGF-BP2, P53. And so we were really seeing that the immune response that we started with this vaccination increased to other proteins expressed on the tumor. And what was very exciting about this particular trial is that we had 22 patients on this trial, and this trial completed about 10 years ago. And 2 years ago, I received an email from one of the patients saying that she'd been vaccinated on this trial. She'd done very, very well. She was still alive, and she just had a recurrence in her lung. And she was asking, can I have another vaccine? And so we went back to the trial, and we looked at the patients, and of 22 metastatic HER2 positive breast cancer patients, we actually had 10 that were still alive 12 years after receiving this vaccine trial. And the majority of them were doing quite well. They were on Herceptin alone or on no therapy, and were doing quite well. So we actually started a booster trial. So just like with the measles, mumps, and rubella vaccine that you first get when you're about 2 years old, and then you get a booster when you're 10 to kind of re-amp up your immune response. We have vaccinated 4 of these 10 patients with 2 more booster vaccines. And really the hope is that we will see an increased immune response and kind of re-trigger their immune system to recognize and to continue having an immune response against these HER2 proteins. So that is a very exciting consideration of improved long-term responses because of developing and changing the immune response with vaccines. We are now moving into looking at, again, when we vaccinate with just one tumor-associated protein, we tend to find that we get antigen-negative variants, is what we call it, but we get tumors that lose that protein but still are able to grow. And so we're trying to now use multiple antigens, so multiple tumor overexpressed proteins in vaccine. This is looking at our mouse data showing that when we vaccinate with 3 proteins instead of each of the individual proteins, the mice do much better and have this increase. Remember, these are these cytotoxic T cells that are important for destroying the tumor and can be directly cytotoxic to the tumor. And we actually have, using these 3 antigens, phase 1 clinical trial. This is now going into stage 2 and 3 breast cancer patients. So these are patients that do not have metastatic disease. And the hope would be that, and they are HER2 negative, so triple negative or ER positive. And the hope would be that vaccinating these patients with this vaccine will prevent them from ever developing recurrence, that you'll allow this immune response to continue destroying any small tumors that would be remaining and prevent recurrence. We've enrolled 1 of 3 arms of this trial. Again, it's increasing doses of the vaccine because we're really trying to determine what the best dose is, the most immunologic dose. And this is a phase 1 study, so really the primary endpoint for us is safety, and it has been very well tolerated so far. So you can see these are the first 7 patients, and most of the side effects have been grade 1 and 2, which are very controllable side effects. We haven't had any severe side effects that have required hospitalization or other interventions, and we have not seen autoimmunity, which we are very much on the lookout for. Another similar trial using multiple antigens is against stem cells, and cancer stem cells is another theory or another thought on how we are getting this cancer dormancy. So cancer stem cells are slower growing than the tumor cells that are growing really quickly and are able to be very plastic. They can go between these lower growing breast cancer stem cells and these rapidly growing cancer cells. And the thought behind this is that when you treat with chemotherapy, you're really able to kill the rapidly growing cancer cells, but you don't target these breast cancer stem cells quite as much as you should. And they're what allows for therapy resistance, relapse, and possible development of metastatic disease. So we can see that again, these autoantibodies that I've talked about are increased to these cancer stem cells in breast cancer patients as compared to volunteer patients. And in our mouse models, we do see that vaccinating against them inhibits tumor growth, both in a triple negative, very aggressive breast cancer mouse model. So these mice are determined to develop a breast cancer, and we're trying to prevent that, as well as in a slightly less aggressive HER2-driven mouse model, and they decrease the number of stem cells, breast cancer stem cells, that we find when we vaccinate in mice. And so we now have a trial that is actually completely enrolled. This was in stage 3 and stage 4 HER2 negative breast cancer patients. Again, testing 3 different doses of the vaccine and trying to again find if this vaccine can be safe and can induce an immune response. And the goal, again, with this vaccine would be for secondary prevention, to prevent someone who'd had breast cancer from having it recur. So, and we're moving this further forward into higher phase studies. So what about ovarian cancer? And there are absolutely vaccine trials in ovarian cancer as well. And one of the vaccine trials that we have been performing is using a protein called IGF-BP2. And if you've been paying very close attention to the slides, you've seen that we have used this in breast cancer as well. This protein is overexpressed in both breast cancer and in ovarian cancer. And that is an excitement of using these tumor-associated proteins, so these overexpressed proteins, is that some of these vaccines that we're developing can be used across different cancer types and may be a target for not just breast cancer, but also for ovarian cancer. So this is looking at our mouse model of ovarian cancer, and what happens with the mice is that we actually give them tumor cells that glow, so you can follow in live mice the tumor and the tumor developing. And when we vaccinate, and this is over a period of time with this protein, this IGF-BP2 vaccine, it's also a DNA vaccine, we see that the mice that would develop cancer do not develop cancer. And we have done a clinical trial of this. Again, it was a phase 1 trial, 25 patients with stage 3 and 4 ovarian cancer, and they had to have no evidence of disease at the time of vaccine. And they received 3 vaccines, as well as there's now been a booster study. And we've developed increasing type 1, remember that's that anti-tumor Th1 immune response, CD4 T cells, as well as those cytotoxic CD8 T cells, and specifically that IGF-BP2, so that vaccine-specific type 1 immune response. We have also been able to, these are very well tolerated. We have had very few more than grade 1 and 2 side effects associated with the vaccine. And when we looked at our survival as compared to the SEER database and matched controls with the SEER database, the patients who had received the vaccine from our study have not yet reached their median overall survival and have actually done quite well. Now, this is a phase 1 study, and so I always put this out with the caveat that these patients were selected because they had no evidence of disease, and really to have a good comparison, you need to have equal patients. Some are vaccinated, some are not, and be able to compare that way. But there are suggestions with this study, and there are absolutely other groups around the country that are vaccinating with a wide variety of targets for ovarian cancer, including NY-ESO, which is a cancer testis antigen vaccine, and being done up at Roswell Park in New York. There are many possibilities of being able to prevent recurrence in these patients with ovarian cancer. The final thing I really wanted to discuss was consideration of combination of vaccine therapy and other immune therapies, or even indeed chemotherapy. And so the idea behind this is really more as a therapeutic, to treat patients that have cancer and to treat and to be able to destroy cancer. There have been many clinical trials that have tried to look at vaccines alone, and they have really not been successful. And so the question is, what can we add to vaccines to improve this? And so this is a study in mice, but this is looking again at that IGF-BP2 vaccine, and we see that treatment with the vaccine alone or treatment with a checkpoint inhibitor, which is an basically takes the immune suppression off of the T cells that are in the tumor, are not as effective as treating with the two together. And so we are definitely looking at adding vaccines plus immune checkpoint inhibitors to try to improve efficacy of both the checkpoint inhibitor and the vaccine. We currently have a study going on that is using this IGF-BP2 vaccine along with chemotherapy in women who have locally advanced ovarian cancer prior to them having surgery. So this is a neoadjuvant, or giving therapy prior to surgery protocol, where we vaccinate along with the chemotherapy that is given to try to shrink the tumors, and then the women go to surgery. And really, we're trying to identify, are we improving their outcome by adding this vaccine prior to surgery? We are considering similar vaccine neoadjuvant strategies in breast cancer, in trying to increase the immune response to the tumor prior to surgery in breast cancer. And so I think that these will also be very important considerations in moving forward. I just wanted to end by showing you a now quite old picture, but a picture of our lab on a rare sunny day in Seattle. They do occur every once in a while. I really wanted to particularly point out Nora Desis, who is the head of the Vaccine Institute and the developer of many of these vaccines that I have been discussing. Work that I've talked about today have also been performed by Denise Cecil in our lab, John Liao, who is our GYN oncologist, as well as a large part of our mouse team and clinical team that are being involved. And then I have my funding here, and I am happy to take questions.
Thank you, Dr. Stanton. So you can submit your questions through the question pane on your window. And while you're getting ready to do that, we have some other questions that we can ask. So someone is asking that in many cases, tumors being tested for gene mutations, should tumors be tested for T cells or CD4 cells or other cells as well?
So that's a very good question. Right now, particularly in breast and ovarian cancer, they are not as a standard tested for CD4 and CD8 cells. There's a big movement, and in the United States, it's through Sylvia Adams and at NYU, who are trying to develop being able to do TIL evaluation as part of the clinical practice, because that really will help with determining immune therapies and how they can be used for a particular patient. Right now in clinical practice, it's pretty much done in colon cancer, which has the most established evaluation of that. But it is something that is definitely moving forward. And what people may have been seeing recently is that there is now this microsatellite instability, that patients that have this microsatellite instability high cancer, regardless of what kind of cancer, can receive immune checkpoint inhibitors. And so in my clinical practice, I have been doing that much more, in that I've been getting my institution to test for microsatellite unstable tumors in breast cancer, because they are much more eligible for receiving, and it is an FDA-approved indication for receiving immune checkpoint inhibitors.
Great, thank you. And are there current vaccine clinical trials ongoing that focus on other subtypes of breast cancer? It seems to be the focus was HER2 positive.
So actually, in our trials, both of the last two trials have been HER2 negative, so triple negative and ER positive. There are absolutely there is a mammoglobin A trial, which is being run out of St. Louis, which is particularly for ER positive. And there are many triple negative vaccine trials, only because triple negative tends to be our most immunologically active tumor. So yes, the answer to that question is yes.
So there's a bunch of questions about disease stages and vaccines, and that it seems that in some of the studies that you talked about, that in stage 4 cancer there was no evidence of disease. Are there ongoing trials where there is evidence of disease in stage 4 metastatic breast cancer?
In our vaccine trials, most again, because we need to be able to give the vaccine time to develop an immune response, most of the studies are in patients that are stage 4 but have well-controlled disease. In ovarian cancer, there are studies of patients that have current disease and progressive disease and are receiving vaccines. And there are other, we have done trials where we have given vaccines and then done things, other immune studies such as adoptive T cell therapy, where we vaccinate to activate T cells and then we take those T cells out, expand them, and give them back to the patient. And in patients that have progressive disease or disease that we need to have more control than we would get with just a vaccine, trials such as that are much more, we've found, are more effective than vaccines alone. So the answer is yes, there are, but often when you have metastatic disease and you still have evidence of disease, trials to look for are trials such as adoptive T cell therapy trials or vaccine and immune checkpoint trials that have a little bit more than just the vaccine alone. Because in the past, the vaccine alone, if you have too much disease, it's just not enough to develop a strong enough immune response to get rid of the disease.
Got it, thank you. And someone is asking if you could tell us a little bit more about the cancer vaccine Briavax in combination with Yervoy or Keytruda.
So Yervoy and Keytruda, I've been talking about these immune checkpoint inhibitors, and those are both types of immune checkpoint inhibitors. And what they are that we know that the immune cells that go to that are in the tumor, those tumor infiltrating lymphocytes or CD8 T cells in the tumor, are there, but the tumor is giving them signals that tell them not to work. And so the Yervoy and the Keytruda are able to go in and basically take away those breaks, those signals that are telling those T cells not to work and allowing them to work. So what Briavax is doing is, I believe it is a 3-antigen vaccine, and it is basically vaccinating patients to increase the immune response to the tumor. And then it's giving these checkpoint inhibitors so that once you've developed that T cell immune response to the tumor, you then take off the blockade that the tumor is giving to not treat and allow that immune response to happen. So that's why that's where you're adding 2 different types of immunotherapy to try to really activate the tumor. Does that make sense?
Yes. Yes, it does. So someone is asking about the efficacy of using Keytruda with a PARP inhibitor. Is that something you can answer or no?
So I know that we have absolutely been, that has been looked at. So again, PARP inhibitors are much more for trying to control cell death and controlling that, and a lot of patients that have PARP inhibitor that are responsive to PARP inhibitors also have a lot of mutations, so that they would have a lot of immune recognition of the tumor. And so basically the thought behind that is that you would add this checkpoint inhibitor because you've got a highly mutated tumor that patients are really recognize, that the immune system can really recognize, and now you're trying to prevent the immune response or try to enhance the immune response of those already infiltrated T cells in the tumor. And the PARP inhibitor is sort of a way to treat that highly mutated tumor in another way. There are absolutely studies out there that are looking into that, particularly in the BRCA mutation patients. We've found that BRCA mutations, remember, they are fixing that BRCA is important in trying to fix mistakes in the DNA, and so they tend to be those tumors tend to have increased mutations as compared to a lot of breast and ovarian tumors that are on the span of mutations not as mutated. They also therefore tend to have because they have a lot more mutations, the immune system sees them a lot more. And so this is really an ability to try to hit both parts of that high mutation and immune together. Does that make some sense? I'm hoping I'm answering their question and not just adding more.
Yeah, thank you. So we're out of time for today. I just wanted to let you know that a couple of people are writing in thanking you for doing this research and doing the work that you do, and we thank you as well. And we'd also like to thank you for a great program. Thank you to everyone for participating. We hope that you'll take a minute to fill out the survey at the end of the webinar. It helps us to create programs that are relevant to your needs. Dr. Stanton, thank you so much. We really appreciate your time. And again, we appreciate
Thank you for letting me talk about my work.
Thanks, everyone.
Thank you.
Thanks.